Hi, this is Swati, Assistant Professor from SNS College of Pharmacy and Health Sciences. Today we are going to see beta adrenergic blockers, which is coming under the sympatholytic agents. So first we see the beta adrenergic blocking agents classification. They are classified into non-selective, that is first generation, and beta selective second generation, non-selective third generation, beta 2 selective third generation. So its mode of action is it is going to bind with the beta adrenergic receptors and block the effects of catecholamines and sympathomimetics on the heart and smooth muscles of the airways and blood vessels. Its chemistry is resembling isoproterenol. Beta blockers should be continued during periodical to avoid reflex CNS hyperactivity. Beta blockage can be reversed by means of beta agonist by the means of displacement from occupied receptors if large amount of agonist is given. So uses is it is going to prevent receptors from responding to nerve impulses, catecholamines and beta adrenergic drugs. The effects of beta adrenergic drugs are decreased heart rate, decreased force of contraction, slow cardiac conduction, decreased autotoxicity of ectopic pacemakers, decreased renin secretion from kidneys, decreased BP, bronchoconstriction, less effective metabolism of glucose. It may be result in more pronounced hypoglycemia and hypoglycemic may be blockers. Decreased production of aqueous humor in eye. So first we see what is meant by beta adrenergic drugs blockers. They are drugs that reduce the heart rate and blood pressure by acting on the beta receptor sites. They also cause bronchoconstriction by acting on the beta receptors and hence should be cautiously used in patients with asthma and COPD. It is going to block both beta 1 and beta 2 receptors, which are going to called as non-selective beta blockers. Already we have seen this classification of beta adrenergic blockers. They are going to be categorized into cardioselective beta 1 blockers, non-selective beta 1 beta 2 blockers, selective beta 2 blockers, alpha plus beta blockers. That non-selective beta 1 and beta blockers again classified into selective beta blockers with membrane stabilization activity, beta blockers with membrane stabilizing and intrinsic sympathomimetic activity, and miscellaneous. Next we will see the SAR of beta blocker. So here there are two important parent structures. One is aryl ethanolamines and next one is aryl oxypropanolamines. Both alpha and beta adrenergic blocking agents. These drugs block the effects of other classification as both the alpha and beta adrenergic blocking agents labetalol and carvedilol. So these are the drugs of beta adrenergic blockers available in the market. First structure of beta adrenergic blocker is propranolol. Its IUPAC nomenclature is 1 orthomethyl ethanolamine, 3 1 naphthyloxy propane 2-ol. It is a non-selective beta adrenergic antagonist. So it is prepared from naphthol epichlorhydrin, which is going to give 1-chloro 3 1 naphthyloxy 2 propanol. That compound is again reacted with isopropanolamine to give propranolol. Next compound is pranolol. It is a beta adrenergic antagonist which is effective for both beta 1 beta 2 receptor. It acts as an antiarrhythmic, antihypertensive and anti-glaucoma agent. It is going to bind with beta 1 and beta adrenergic receptors, but its mechanism is still unknown. It is used to treat elevated intraocular pressure in patients having ocular hypertension or open-angle glaucoma. Next drug is atenolol. It is a most selective beta 1 blocker. 50% of the dose is absorbed by the gastrointestinal agent. Little or no hepatic metabolism. Renal excretion. Its elimination half-life is about 6 to 8 hours. IV dose for acute migraine. Preoperative toxicology will decrease incidence of post-OPMI in CAD peoples. It is going to enter CNS in very small amount, but fatigue or depression still occurs. It can be used with caution in IDDM peoples whose HTN is not controlled with other anti-HTN does not potentiate insulin-induced hypoglycemia seen with non-selective beta blockers. Next drug is betoxolol. It is a cardioselective beta-1 adrenergic antagonist having no partial agonist activity. It is used for managing hypertension. Next one is metoprolol. It is beta-1 selective drug. It is having high hepatic first-pass metabolism and it is lower protein binding. Elimination half-life is about 3 hours. It is used in COPD, PVD patients. Next drug is bisoprolol. It is a salt of synthetic phenoxy 2-propanol derivative cardioselective beta-1 adrenergic antagonist. It has antihypertensive and cardioprotective properties. It is similar in structure to metoprolol, azibutolol and atenolol as they all have two substituents in the para portion of the benzene ring. It is used for managing heart failure, angina pectoris, mild to moderate hypertension and for secondary prevention of myocardial infarction. Next drug is esmolol. It is a cardioselective blocker of beta-1 receptor. It is having rapid onset of action and very short duration of action. It is rapidly used for controlling the ventricular rate in patient having a trial fibrillation or trial flutter in perioperative, postoperative and other emergency conditions, which is going to require short-term control of ventricular. It is also used for controlling the rapid heart rate in non-compensatory sinus tachycardia. Next one is labetalol. It is a non-cardioselective blocker of beta-adrenergic receptors. Next one is carvedilol. It is a non-selective beta blocker prescribed especially for treating mild to moderate congestive heart failure. It is used for treating mild to operative heart failure of cardiomyopathy and ischemic origin. Thank you.